Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome back to the Deep Dive, presented by the Surgical Edge podcast. Today we're tackling a really critical topic for anyone looking after surgical patients, high-output stoma, or HOS.
Right.
We're going deep into the diagnosis and, importantly, the very structured way it's managed.
It's definitely high-stakes stuff. HOS isn't just about a leaky bag, is it? It's a serious systemic issue, most often popping up with jejunostomies, or those very high ileostomies. If you don't catch it early, well, it spirals fast.
Into what exactly? What are the immediate dangers?
We're talking potentially life-threatening dehydration, electrolytes getting completely out of whack, and not just sodium. Magnesium is a big one, too, and almost inevitably, the kidneys start to fail. Pre-renal AKI.
Yeah, and our sources, particularly looking at the UK model and guidelines from groups like the ACP-GBI, they really hammer home this structured, team-based approach.
Absolutely. The whole philosophy is, spot it early, hit it hard with resuscitation, and then follow a very clear, stepwise plan to escalate treatment if needed.
Okay, before we really dive into the nuts and bolts, though, there's the standard disclaimer we need to mention.
Yes. Crucial point. Everything we discuss today is for education and reference. It's not a substitute for your own clinical judgment or, importantly, your local hospital guidelines and protocols. Always follow those.
Always. Couldn't agree more. Right then, let's get into it. The definition first.
Right.
What technically is a high-output stoma? Because, like you said, we often get worried before hitting that official number.
That's a great point. So formally, the textbooks will say an output consistently over, say, 1,500 to 2,000 milliliters per day for a couple of days running.
Okay.
But practically, if you're seeing output persistently creeping over 1,000 milliliters in 24 hours, especially if the bloods are starting to look a bit dodgy,
Right.
Yeah, alarm bells should be ringing already.
So don't just rely on the number in the chart. What about the patient in front of you? What clinical signs scream HOS?
Well, it's the classic picture of someone who's just losing way too much fluid. They'll often tell you they're incredibly thirsty, like a thirst they can't quench. You'll see dry mouth, dry mucous membranes, maybe their heart rate's up, tachycardia. Postural drop in blood pressure is common too.
And the kidneys give us a clue.
Definitely. Look at the urine output. If it's dropping below that standard marker, maybe less than 0.5 ml per kilo per hour, that's a really objective sign. They're seriously volume depleted.
Okay, so you've got that clinical suspicion, time for the blood test to see how bad things are. What are those classic electrolyte hits we expect?
Right. The UNEs, the urea and electrolytes panel, gives you that instant snapshot. Characteristically, you'll see low sodium, so hyponatremia, and low potassium, hypokalemia. They're just pouring out in the stoma fluid.
And the kidney function.
That volume loss and electrolyte chaos directly leads to the pre-renal acute kidney injury. So you'll see the urea and creatinine climbing on that same panel.
You mentioned magnesium earlier as being particularly important.
Yes, absolutely. Don't forget the magnesium. It's so common to see profound hypomagnesemia with HOS, and low magnesium is often the culprit behind some really scary symptoms. Muscle cramps, pins and needles, tetany, even full-blown seizures. It needs specific, often slow replacement.
And I suppose a simple test like a full blood count can also give a quick clue about dehydration.
It can, yeah. If the hematocrit, the proportion of red blood cells, is high, that suggests hemoconcentration, basically. The blood's more concentrated because the fluid part is low. It backs up the picture.
Okay, one crucial step before we jump into treatment protocols.
Yes. Infection. You have to rule out an infective cause. So stool samples for microbiology, culture, and sensitivity, MCNS, and specifically a C. difficile toxin test, or PCR.
Why is that so critical?
Because the last thing you want to do is give antimotility drugs like loperamide to someone with infectious colitis or C. diff. You could make things much, much worse. Got to exclude that first.
Makes total sense.
Yeah.
Right. Assuming no infection, we move to management. Step one is hitting the dehydration hard. 4V fluids are a must if they're dry or have AKI. Does the type of IV fluid matter?
It really does. The preferred choice, certainly in the UK guidelines, is Hartmann's solution, or lactated ringers in the US.
Over standard normal saline?
Yes. The issue with chucking in lots of 0.9% saline, especially quickly, is the high chloride load. It can cause or worsen a hyperchloremic metabolic acidosis, which just adds to the patient's problems. Hartmann's is more balanced.
Okay, so Hartmann's for volume. And alongside that, we're obviously replacing the electrolytes they've lost intravenously.
Exactly. Potassium needs replacing, and as we said, magnesium often requires dedicated, slow infusions. You can't just push magnesium in quickly, it doesn't replete the stores properly, it takes time.
Right. So once they're stabilized from that initial hit, we need to slow down the gut transit. This is where the drugs come in, starting with loperamide, but not the usual dose.
No, definitely not. We're talking high-dose loperamide, often starting somewhere like 4 to 8 milligrams 4 times a day. And the timing is key.
Ah, tell me about the timing.
You give it 30 to 60 minutes before meals. The idea is to have the peak antimotility effect hit just as the food and drink stimulus arrives in the small bowel, maximizes the impact.
Clever. And if loperamide alone isn't cutting it,
Then you add in the next layer. Codeine phosphate, usually 30 to 60 milligrams 4 times daily, works synergistically with loperamide to slow things down further.
okay, loperamide plus codeine. But we're not just stopping the flow, we also need to reduce what's going into the gut.
Precisely. A huge amount of the stoma output isn't just what the patient drinks, it's their own gut secretions, stomach acid, bile, pancreatic juices, can be liters a day.
So we need to turn off that tap too.
Exactly. That's where anti-secretory agents are vital. High-dose proton pump inhibitors, like omeprazole 40 milligrams twice a day, or sometimes an H2 receptor antagonist like famotidine, though PPIs are usually first line now. They significantly reduce that baseline fluid secretion volume.
Okay, this brings us to maybe the most counterintuitive part for patients. Fluid advice. This seems to be where things often go wrong.
It is the most crucial non-drug step, and yes, it feels totally wrong to the patient. When you have a proximal stoma, a jejunostomy, or high ileostomy, you must tell the patient to strictly limit drinking plain water, tea, coffee, any free fluids.
That sounds incredibly difficult. You're telling someone who feels desperately thirsty not to drink the very thing they crave. Why is plain water bad here?
Because the fluid coming out of that proximal stoma is already quite salty, isotonic, or even slightly hypertonic. When they drink plain water, which is hypotonic, very low in salt, it actually acts like a magnet in the short bit of bowel they have left. It pulls more sodium and electrolytes out of their body into the gut, and then it all just rushes out the stoma.
So drinking water paradoxically makes the dehydration and salt loss worse.
Exactly. They get temporary relief in the mouth, but biochemically, they're getting more dehydrated and losing more salt. It's a vicious cycle.
What should they drink instead of water?
They need to sip on specific glucose electrolyte solutions. These are designed to be absorbed properly by the remaining bowel.
And the classic one, especially in the UK literature, is
St. Mark's solution. It's kind of the cornerstone of oral fluid management for HOS in many centers.
right, the famous St. Mark's. For listeners maybe not familiar, what's the principle? It's basically a prescribed recipe, isn't it?
It is. It's a specific mix of salt, sodium chloride, sodium bicarbonate, and glucose, or a glucose polymer powder dissolved in water. The key is the precise concentration. It uses the gut's natural mechanism where sodium and glucose are absorbed together and water follows them. So it actively promotes absorption of both salt and water.
And how much do patients typically take?
Standard advice is often around 1 liter per day, sipped throughout the day instead of plain water.
Okay, that's fluids. What about food? Any specific dietary tweaks to help?
Yes, small, frequent meals are generally better than large ones, and we encourage foods high in soluble fiber. Think things that go a bit sticky or gel-like. Mashed banana, porridge or oatmeal, apple puree, maybe smooth peanut butter. That soluble fiber helps to thicken the stoma output.
And thickening helps how?
It physically slows down how fast things move through the short bowel segment, giving more contact time for any remaining absorption of nutrients and electrolytes to happen.
Right. Okay, so we've tried high-dose meds, the St. Mark's solution, dietary changes. But the output is still stubbornly high. Maybe the patient keeps needing IV fluids. What's the next escalation point?
If you're failing maximal medical and dietary therapy, it's a mandatory referral to a specialist intestinal failure team. These are multidisciplinary teams, usually in tertiary centers.
And what do they bring to the table?
They assess the need for parenteral support. That might mean supplementary IV fluids and electrolytes in the short term, perhaps as an outpatient service. But if the gut simply can't absorb enough long-term, it means considering home parenteral nutrition, or HPN.
So nutrition delivered directly into the bloodstream via a long-term central line at home.
Exactly. It's a life-saving therapy for patients with irreversible intestinal failure, type 2 IF. But alongside managing the output, we also need to figure out why it's so high if there's an underlying cause we missed.
Good point. What's the standard workup for finding a cause?
First-line imaging is usually a CT scan of the abdomen and pelvis, and make sure you give oral contrast. You're looking for anything structural, maybe a hidden access, signs of active Crohn's disease that wasn't controlled, adhesions causing a partial blockage, even tumor recurrence.
And if you suspect the problem is right at the stoma itself, like a narrowing.
Then you might do more specific tests. A stoma jejunogram, where contrast is put directly into the stoma under imaging, is great for looking at that very proximal bit of bowel for strictures or kinks. Endoscopy through the stoma might also be needed, especially if you suspect ongoing inflammation like IBD.
Now, surgery is generally seen as a last resort in these cases, isn't it? Because you risk making the short bowel even shorter.
Absolutely. Surgery is really reserved for two main situations. One, complete failure of all the medical, dietary, and supportive therapies we've discussed. Or two, if you've actually found a specific structural problem on the scans that needs fixing surgically.
What kind of surgical options are there?
It ranges. Sometimes it might be a relatively straightforward stoma revision or resiting if the current one is badly constructed or strictured. The ideal, if possible and safe, is always stoma reversal, reconnecting the bowel.
But reversal isn't always an option.
No. Often the reason for the stoma in the first place, or the length of remaining bowel, makes reversal impossible or too risky.
And for those really complex patients, maybe on long-term HPN due to very short gut, are there super specialized surgical options?
Yes, but these are performed only in highly specialized national intestinal failure centers. We're talking about bowel lengthening procedures like the Bianchi procedure or a step procedure. These are complex operations aiming to increase the absorptive surface area of the short gut.
Wow. And beyond that?
Beyond that, the absolute final frontier is intestinal transplantation. But that carries significant risks and is reserved for very select patients with life-threatening HPN complications.
Okay, let's shift gears to long-term stability. Getting someone through the acute crisis is one thing, but keeping them well and out of hospital requires ongoing coordinated care.
Hugely important. This relies on a really effective shared care model between different teams.
Who are the key players?
Well, the primary care physician, the GP, plays a massive role. They're often managing the repeat prescriptions for the high-dose loperamide, codeine, PPIs, maybe electrolyte supplements. And crucially, they need to do regular blood monitoring, checking those UNEs and magnesium levels. Weekly at first after discharge, then maybe monthly or every few months once stable.
Okay, so GP is vital for monitoring and prescribing. Who else?
The stoma care nurse is absolutely pivotal. They're often the patient's main point of contact, providing ongoing education, troubleshooting stoma issues, reinforcing all that complex fluid and diet advice, checking skin integrity around the stoma. They really coordinate a lot of the day-to-day management.
And the hospital team.
The specialist surgeon and the intestinal failure team provide the overarching guidance and periodic reviews, maybe every few months or annually, depending on stability. They adjust the long-term plan and manage any complications.
It sounds like the patient themselves needs to be highly educated and involved too.
Oh, completely. Patient empowerment is key. They need to understand why they're taking these meds, how to properly mix their St. Mark's solution if they use it, how to recognize the early signs of dehydration themselves.
And adjust things based on output.
Ideally, yes. Many stable patients learn to titrate their loperamide dose slightly up or down based on their measured daily stoma output within agreed parameters. That level of self-management is what truly allows them to live safely and effectively in the community.
That really paints a clear picture. It's a pyramid, isn't it? Starting with spotting it early, then that aggressive IV resuscitation, layering on the high-dose drugs, getting the fluids right with things like St. Mark's, and then escalating to specialist IF support if needed.
That's a perfect summary. And underpinning it all is that coordinated follow-up.
Well, thank you. That was a fantastic walkthrough of a really complex but manageable condition when approached correctly.
My pleasure. It highlights how crucial teamwork is in surgery and medicine.
Absolutely. And maybe a final thought for you, our listeners, to take away. Think about that coordination piece.
Yes. How seamless is that transition and shared care pathway in your local system? Because ultimately, the success in managing HOS long-term, keeping patients safe and well at home, really hinges on how well the patient, primary care, the stoma nurses, and the specialist teams all work together.
A really important reflection. Okay, that's all we have time for on this deep dive. Thanks for tuning in to the Surgical Edge podcast. We'll catch you next time.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.